afternoon, and thank you for the introduction, Hina. This presentation will focus on safety considerations for patient instructions for use to minimize medication errors. We've seen this disclaimer slide a few times today, but as a reminder, the views and opinions expressed in this presentation do not necessarily convey official FDA position. So in this presentation, we'll go over best practices for developing patient instructions, also discuss the review process from the patient labeling team's perspective and the medication error team's perspective, including the role of human factors validation studies in optimizing instructions for use. And lastly, we'll discuss how these two divisions come together for an integrated review of instructions for use. As more complicated dosing regimens and delivery devices are introduced to the market, there's also a need for proactive risk assessments to inform the design and content of labeling in order to ensure this labeling is clear and promotes safe use. There's also a greater awareness on the content and format of all labeling of these medications to ensure that they have a proper focus. This attention has gone not just to the prescribing information, but also to the carton labeling, container labels, and instructions for use. Our instructions for use are developed by sponsors and reviewed by FDA and are ultimately considered part of FDA-approved labeling. They might be a separate document or part of a medication guide or patient package insert. We typically see IFUs recommended for products that have complicated dosing instructions. This might be an oral solution that requires users to withdraw a weight-specific dose using an oral syringe. We also see IFUs recommended for products that have a device component, including an auto-injector or an inhaler. IFUs have step-by-step procedural instructions for how to use a product, and they might also include visuals or graphics in order to emphasize those steps. And you might also hear the term quick reference guide. This is an abbreviated version of instructions for use. So when creating an IFU, a few different portions of the prescribing information are considered. This includes Section 2, dosage and administration, as well as our house supplied section and patient counseling information. So the data from these sections is gathered and then reformulated into a document that can be readily understood by our lay users, and thus the IFU. Our patient labeling team is within the Division of Medical Policy Programs, DMPP, and they are an integral part of the review of the IFU. Patient labeling team's review looks to see that the IFU has simple words and concepts so that the reading comprehension label is reflective of the intended users and doesn't have technical jargon and healthcare terms that we might expect to see in the prescribing information. The patient labeling team also ensures that the IFU doesn't have unnecessary information and doesn't overly repeat information that's not necessary to understand the safe use of a product. Our patient labeling team ensures that the IFU follows all applicable regulations and guidance documents, and lastly ensures that this information is aligned with the prescribing information. The Division of Medication Error Prevention and Analysis, DMEPA, also reviews the IFU from a medication error perspective. And in this review of the IFU, DMEPA ensures that the instructions are clear for the patients and caregivers. DMEPA reviews the information and graphics regarding how to use the product to ensure that the information is clear, it's consistent, and it's presented in a logical order. DMEPA also reviews the information regarding how to maintain or store the product and troubleshooting information. DMEPA reviews includes ensuring that there are no error-prone abbreviations or symbols. While we all might know what BID or TIW means, this might not be readily understood by our lay users. And lastly, if human factors validation studies are conducted to support instructions for use, DMEPA will review the results from that study to determine if feedback should be incorporated into the IFU. And so this presentation is not intended to give a full overview of human factors studies, but there are a few concepts that will be important to understand in order to understand how human factor studies can be utilized to improve instructions for use. So human factor studies are conducted to demonstrate that the intended users of a product can safely and effectively use the product for its intended uses and in the expected use environments. Our intended users can vary between patients, caregivers, healthcare providers, or any combination of the three. And our expected use environments might be home use, hospital use, emergency use, or any associated sub-environments. Human factors engineering process can be helpful in identifying use-related hazards associated with the product's overall design or the labeling. And conducting human factor studies allows manufacturers to make revisions to a product's design or label prior to introducing a potentially confusing product or labeling to the market. Implementing human factors engineering and the design process can improve instructional materials. Formative evaluations are conducted early in the human factors engineering process while the user interface is still in development, and they are considered iterative in nature. And conducting formative evaluations can help identify areas of improvement within the labeling and overall user interface, including our instructions for use. Participant performance or subjective feedback from human factor studies may identify vulnerabilities in labeling. For example, if the results of a human factors validation study identifies use errors or participant difficulties with critical tasks, this may indicate that additional revisions or mitigations are needed to mitigate risk. There might also be the need for additional data to ensure that any mitigations that are implemented are acceptable and reduce risk to an acceptable level. Human factors engineering and the overall process can be helpful in improving our labels and labelings, which is part of the product user interface. But it's important to note that even optimized labels and labeling do not replace the need for overall good product design. So we've briefly discussed a few human factors concepts, and the next few slides will provide examples of those concepts. We talked about the user interface, and as this image shows, we have packaging, labels and labeling, a device contained within the carton, as well as instructions for use. All of these components are considered part of the user interface, which is any component of a product that a user interacts with, and it should be tested in human factors studies. If a quick reference guide is utilized, it may also be included as part of the user interface. We also talked about human factors study timeline and formative evaluations. So as you can see from this sample timeline, formative evaluations occur earlier in the human factors development process, while the user interface is still being developed, not finalized yet. And as we proceed through the process, we reach validation testing, which occurs when you have your final device design. It's important to note that this timeline is a sample timeline, and other timelines might be acceptable, including conducting your validation testing in parallel with phase 3 studies. We also discussed how your IFU might be improved through conducting human factors studies. In this table, we have a sample formative study for an injectable product. In this study, there were 15 study participants who reviewed the IFU and were asked to simulate the injection using the IFU. For this product, it's important to note that there are 3 injection sites: the thigh, the abdomen, and the arm. The thigh and abdomen can be used for self or caregiver administration, but the arm is only for caregiver administration. We see in the summary of key results that 3 patient participants did not identify the correct injection site. They identified the arm, which again is only for caregiver administration. In those results and in that participant feedback, the patients noted that the IFU could have been further improved by including a graphic to appropriately label the injection sites. So as a result of this human factors formative evaluation, the IFU was updated to provide additional graphics and clarify the injection sites. So we see an example here of how human factors testing can be really helpful in improving your user interface, including instructions for use. So we've talked about best practices for developing patient instructions, the patient labeling team's review, our medication error team's review, and also the role of human factors studies. Lastly, I'd like to discuss how our patient labeling team and medication error teams come together for an integrated review of our patient instructions. The teams work together and consider the IFU content, layout, and design, as well as human factors data. By working together, these 2 divisions have adapted their review processes to allow for early review of the IFU materials in the IND phase, and a map is being developed to formalize this process. Our patient labeling team and medication error teams will perform initial independent reviews of the IFU or quick reference guide if included. Then the two divisions will come together to discuss and align recommendation. And it's our hope that by formalizing this process, we can provide an integrated set of efficient recommendations for the sponsor. This concludes my presentation. The next two slides provide additional resources that might be helpful in understanding the concepts we discussed. And I'll turn it over to Laurie. Thank you.
Thank you very much. So thank you to those of you who have stayed for the last presentation on the last day. I appreciate it, and hopefully we'll make it worth your while to have stayed. I wanted to take 2 seconds and just explain what Global Health Literacy Director means, because there's only 2 of us in the industry, actually, with the title Health Literacy in our title. And basically, I work across different divisions of the company and different parts of the world to help to try to make information for patients as simple and clear as we can. So this is one of the most important projects that I work on. Of course, the disclaimer. So I want to start by defining health literacy. It is likely a term that many of you have not heard. So let me make sure you understand what it is before I talk about applying it to labeling. I want to share a process that we've developed over a number of years to develop and test health literate patient labeling, and then I want to give an example. How do you take an actual physician labeling and make it into a clear document that patients are able to understand? And so let me start with the US definition, because that's where we are today. So the US definition of health literacy focuses on the ability to obtain, process, and understand health information to make appropriate health decisions, rather than informed. We're evolving. But what that really does is places the burden of understanding on the patient. And the reality is that every communication is a two-way exchange. And so, this is where I come into play and where Merck comes into play. People usually think of the doctor being the one who communicates with the patient, but there's many other players in healthcare. So what can we do to simplify communications to really reduce the risk of patients misunderstanding? And that's at the core of this. The example I always like to use, and Lena could say it, she's heard it probably a dozen times, but my graduate degree is in healthcare. And so I'm among the 12% of Americans with proficient health literacy. Yet my daughter had surgery to remove a birthmark on her leg. And they told me to limit her activity. Kids are active. They play travel sports. So to me, that meant don't go to travel soccer practice. That didn't mean sit on the sofa, put your leg up, and rest for 3 days. If the discharge nurse had said that, I would have done that. My poor kid, I walked her around a small children's museum the next day, and her leg started to bleed, and she needed another surgery. Any working mom has plenty of guilt. Add this to the list. And again, limit activity, simple language, but the communication was not clear. And so things can be quite subjective, so the more we can make it clear. Another example is once daily. So once in Spanish, the number of people taking, native Spanish speakers taking a medicine 11 times a day, unfortunately, because of the use of the word once rather than 1 time a day. So there's many examples of this. I wanted to also highlight that, those of us in the room are absolutely in the 12% of Americans with proficient health literacy. Yet is there anyone who has said that they have always understood all the health information that's been given to them? I think I've had one person in like 3,000 raise their hand at this point, right? And so every single one of us who are proficient health literacy has at some point or another struggled to understand health information. Maybe it's because of a diagnosis that's emotionally overwhelming, but it's a universal thing. But that being said, there are certain risk factors for low health literacy. And I just wanted to reiterate, these are the same risk factors for chronic disease, right? And so much of what we do is create patient labeling for people who have chronic disease. We have to think about health literacy in these discussions. I also wanted to quickly acknowledge that this is really truly a global health issue. So Christine Sorensen did a survey in 8 countries in Europe, and about half of folks have limited health literacy. There's been recent work to attempt to validate this in other countries. But This is truly a universal challenge, regardless of where you are in the world. So with that being said, I want to say we've always tried hard to make sure that our patient labeling is clear, right? It's same as every patient communication. But that being said, you learn, right? You evolve. We've heard that theme many times today. And so we have always done comprehension testing of new, and again, I'm talking about new molecules here, right? We're about looking ahead. We've always done comprehension testing, and we used to stratify across education level. We thought that was enough. And when we actually started adding a health literacy assessment to this, guess what we found? People who may not have graduated high school were quite confident in their ability to talk about health, were the ones volunteering, right? So we really didn't have people with limited health literacy in our testing. And so those who we did had lower comprehension scores directionally. So we said, we really want to do something about this. This was probably 5 or 6 years ago. The most important member of that team was legal, because we needed to make sure that she was comfortable with what we were doing. We had others with global regulatory policy. We had, at the time, Mike Rosenblatt was our chief medical officer. It was very much a senior level group putting their heads together, the heads of labeling, and saying, what can we do about this? We very quickly realized we weren't really quite sure, but there were other people who were doing great work. So Dr. Ruth Parker at Emory and Dr. Michael Wolf at Northwestern were doing a lot of work actually around the PMI at the time with different formats. And Ruth is really a leader in the field. So at a health literacy research conference, I approached her and I said, would you ever want to help us with this? And she said, we always publish our stuff in journals, but to have the opportunity to work with a company to actually make this real for patients. And so that's kind of how we all got on board together. So how it works. So we start, first of all, we start much earlier than I think typically you do with patient labeling, right? Usually this is about 5 months before you actually file. And I'm going to explain to you why it kind of takes that long. But Merck has ownership of the document. So we develop the initial draft of the patient label. Sometimes you're actually still working with interim data. But we all know that there's a lot of information that we already do have to help to formulate that, right? And as we go along, we can tweak it. So we give it to Northwestern Emory, and we ask them to apply evidence-based best practices. This isn't just what somebody thinks. These are things that have been proven to work. And so the example that I'm going to talk about later is for the treatment of, it's used for people who have had C. diff come back. So we sent it to Northwestern Emory, and our final indication got tweaked slightly, so I know that. But we sent it to them for prevention of the recurrence of Clostridium difficile infection. And it came back to us to help keep C. diff from coming back. Oh boy, isn't that better, right? Actually, a lot of patients don't even know the term C. diff. They use the term severe diarrhea, right? So again, it's not rocket science. It's just a different way of thinking and framing your communications, which I think is exactly what you just talked about. And then it comes back to us, and we really try to honor the recommendations. They've been each working in this field for many years. I think they've probably each published over 200 articles. So we really try to do that. And that sometimes takes me slightly outside of my comfort zone, because often I'm having conversations with vice presidents of research who think that what they said was really clear, but it's really not. And so, I need to say, no, really, we need to listen. And there's tremendous respect for this process. And they really do, people really have come to very much respect the recommendations. So the next thing that happens is testing. And so this round is actually, the focus groups are actually led by Dr. Wolf and Dr. Parker and their teams. Kara Jacobson at Emory and others at Northwestern as well have just been phenomenal. And so in focus groups, we really do 2 things. Number one, we put the draft label in front of people and find out if there's things that we thought were clear that actually aren't, right? And sometimes that happens. The other thing is sometimes there are things we don't know quite how to say. So we might take in a picture of a rash and say, how would you describe this in your own words? Again, it takes us slightly outside of our comfort zone. yeast infections. Dollop of cottage cheese on a napkin. How would you describe this in your own words, right? But what it does is it helps us use the language that people use in describing these things. Another thing, by the way, we found out very quickly and very early is drug. We need to use the term medicine because drugs have very negative connotations, right? And so again, these are insights that are really important. So then we go into comprehension testing, and this is run by Merck. And this is where we all kind of used to start initially with our testing and make sure that things were understood here. I can tell you this process works a lot better. So we do qualitative research. We do that with about 60 people. We used to actually do about 100 before this whole process, but we found that at this point, we're really just tweaking because the rest of it has gotten us to a place that's very good, if we even need to tweak it at this point. So we actually aim for 25% of people with low health literacy. I'm going to talk in a second about how we achieve that. But that's a pretty big number, and it means you have to do things pretty differently. So I'm going to talk about that in this slide. And how we think about dividing up those people are people who may not have or who don't have the disease, but who match the demographics of people with the disease. People with the disease, and then if it's appropriate, caregivers. And then again, we have the final report out. We have Northwestern and Emory in the room, and we work through real time what are the edits that we may need to make to the label. And usually, again, it's pretty minor at this point. So I want to talk for just a second about testing. So there's a few things we've done to really help to beef up the inclusion of people with low health literacy. So the first, Schlesinger is an organization that many pharma companies use for market research. So they actually started adding, there's a kind of a preliminary health literacy question we use, and then there's a final test. I'll talk about that in a sec. But they actually ask people who are new respondents, how confident are you filling out medical forms by yourself? That actually is a pretty good predictor of people's health literacy. It's not perfect, but it gives us a way to preliminary get some people in that are at greater risk of low health literacy. Then we also do, I've already talked about the health literacy assessment. When we actually have people, the final assessment is based on something called the newest vital sign, which actually Pfizer did many years ago. But it's about reading an ice cream label. And so for instance, if the ice cream label, one serving has 200 calories, and you're allowed 2,000 calories in a day, what percent of your daily caloric intake is that? Of course, it's 10%. Numeracy is, and the understanding and use of numbers is such an important skill in healthcare. If you think about diabetes and insulin, if you think about many other things, that we really feel like that is the most, that is a really good predictor of health literacy, and one that's really important rather than just using truly vocabulary types of tests. So again, we really spend time to find people with low health literacy. So we actually sometimes have to go to literacy centers or to senior centers. When I first came into this role, we excluded people over age 70, and I couldn't quite get an answer of why we did that, so we stopped doing that. One of our products that actually never got filed, but we actually had 2/3 of the people in the comprehension testing were over age 65. That's a pretty big deal. And so, no requirement for desktop computer. Again, we don't know what we don't know until you start to ask. We used to require a desktop computer. Well, if you think about low socioeconomic status is a risk factor for low health literacy, people generally have their smartphones. They're less likely to have desktop computers, and so we were inadvertently excluding people from lower socioeconomic statuses, at least some of the time. So now, desktop computer is one option, but if you don't have that, we'll mail you something, right? And you can open it at the beginning of the testing. So we've really tried to think a little bit, again, for a pharma company, this is out of the box, about how we find people. And then for people with low health literacy, we really try to do that testing in person. An important aspect of this is the moderators really understanding health literacy and making people feel comfortable that there's no right answers, that we just want their opinion and we really want their help when things aren't clear. That's a skill that needs to be developed as well. And then we do a combination of open book and closed book assessment. And again, if there's a question about a medicine, people can look for resources. But at the end of the day, with the closed book, you need to be able to say, what is the medicine for? What are the serious side effects? What are the common side effects? And how do you take it? Those are kind of the core questions within our closed book assessment. And it works. We've now, across probably 10 different labels in development, more or less, had almost 800 people. And what you find is that people with both limited and adequate health literacy can understand the label. And I'm about to show you one in a second. This is pretty astounding because Mike Wolf was the lead author on a paper in 2012 that showed significant comprehension difference between people with adequate and limited health literacy. It's not apples to apples. It's not exactly the same way. But this is a pretty significant achievement, I think. And patients love it, not surprisingly. They said they'd be, you hear quotes all the time from people with low health literacy saying, usually, it kind of scares me. But this, I feel like it's approachable. I can read it. I can understand it. And they feel empowered. And so they say they're more likely to read it, to keep it as a reference, to understand how to use it, to have a clear understanding of risks, and to ask questions. Now, we're not talking today about kind of, once a product is approved. But when you think about the downstream impact, right, your patient label informs all of your product communications to patients after approval. If we can get this right, it's going to make all of those things better down the road as well. So obviously you cannot read this, but the point of this isn't to be able to read it. I want to show you how different. This is the entire approved label for Zymplava. What you see is it isn't just language. You see white space. You see bullets, you see formatting. And so I want to just reinforce that this is more than language exercise. This is thinking about other elements of communication that enable strong comprehension. So now I want to talk you through one actual product. And anybody, by the way, I'll give my email at the end of this. I will talk to anybody about this. I've talked to plenty of other pharma. I've talked to whatever. So if you want to go back and say, help me understand how to do this, I'm happy to. But this is here as an example. So again, I'm not going to read every word. But here's the PI and here's the PPI. So you see, I'll just go to what is Zymplava. It's a prescription medicine used to help decrease the risk of C. diff from coming back. Right? It was at least close to what we originally had. In people 18 years of older who are receiving antibacterial drug who are taking an antibiotic for C. diff and who have a high risk of C. diff coming back, right? I'm going to keep going. This was one we spent hours and hours on. So the heart failure risk was pretty complex, as you can see above. I mean, we really, and when I say safety, legal, many of us in the room to try to make this understandable. So what we ended up with is it may cause serious side effects, including heart failure. It can happen in people who receive Zymplava and can be serious. People with a history of congestive heart failure, CHF, again, important, give people the language they use, who received Zymplava had a higher rate of heart failure and death than those who did not receive Zymplava. Pretty clear, right? And you think about, it's pretty complex data at the top. Again, I'm not going to go through all this, but I'm going to go to the next slide, which is what are the possible side effects of Zymplava? Again, based on feedback from patients, we divide it into side effects that can happen the day or the day after receiving the medicine versus side effects that can happen up to 4 weeks later. And you see our USPI term versus our patient-friendly term. So even over time, patients understand the word nausea. We weren't sure about that, but they do. Headache is clear. Again, fever, even something like fatigue that I think we take for granted that people will understand. Feeling tired is so much easier to understand, right? Dizziness, again, feeling dizzy, much simpler. Hypertension, high blood pressure. The AMA has a wonderful video, 5 minutes or less. It's the AMA Health Literacy short version. And there's this very kind gentleman who's very warm. And he says, yeah, my doctor gave me medicine for hypertension. Well, why did she do that? Because she thinks I'm hyper, right? And so, again, it's powerful, but you don't know what you don't know until you listen to patients. I was just sharing with Ebony before this, we have a product we're working on now, and it is for people, one of the lines is for people who have never been treated before. Everyone with adequate health literacy got that right. A whole bunch of the people with limited health literacy got that wrong. And I was shocked. They missed the word never. So they read it as for people who have been treated before. Again, I'm learning, I still learn every day, almost 7 years in from listening to patients. So we actually added words for people new to treatment who have never been treated before, right, to help to increase, really address the needs of people with low health literacy. So I want to leave you with, it is possible to create labeling that's well understood by individuals truly across all health literacy levels. It requires a thoughtful approach. I mean, this is harder than developing your patient labeling in the last, few weeks before filing, right? It takes more time. But I really believe it's worth it. And I think everyone in our company has come to believe that this is absolutely worth it. And again, this is based on evidence-based best practices. And I'm happy to talk to anybody who's interested. I'll give you the name of our contact at Schlesinger. I mean, really, this is something it would make me thrilled if every company did the same process. So thank you.
And thank you, Lori, for that. We are going to go into Q&A now. Our panel is all set. I've seen the questions coming in online. For those of you online, please keep putting those questions in. The Q&A pod that's down in the lower right-hand corner is where you type those in, and we'll pull those together in the back of the room here so we can read them out. But we've got people lining up in the microphones. Anne-Marie right there in front. Please, once we get that on, Anne-Marie, lead us off with the first question.
So, Lori, this question is for you. Once you've done a focus group and you've identified, let's say, dyspnea, patients understanding shortness of breath, have you developed like item banking that you store that information for the next product, or do you retest for another product that may have a shortness of breath as one of their symptoms again?
Yeah, so every single new molecule label we test, right, if we have new labels. Right now, the knowledge expertise is me. So I sit on every labeling call for every new molecule for the US. But as you can imagine, that's kind of a lot, especially when I do other things. So, again, this is an evolution. We actually just had over 100 people from our research division go through a day of health literacy training a few weeks ago. So we're working and trying to figuring out a process on how do we enable people with this skill so that they own it more and I own it less. But the other thing we're actually, I just had someone start a special assignment for me, trying to think about glossaries, right? So for instance, if the FDA has approved a term that's clear, can we somehow guide people to find that so they don't have to reinvent the wheel? So these are the things that we're thinking about now. But right now I go in and say, oh, we tested that in this label, so we need to do this. But
okay, let's go to microphone number 1, please. Go ahead.
Yes. Hi, this is Gina Montero from Eli Lilly, and this is a question for the FDA. It's not necessarily about health literacy, but it's about QRGs. In the past, we've gotten feedback that that these were promotional, and so shouldn't be submitted to the review division. It needs to go to OPDP. We haven't seen that necessarily consistently, so just trying to get some feedback on, when do you know to submit a QRG as labeling versus promotional?
I can speak from the DMEPA perspective. For a QRG, we consider it as part of the user interface. So we expect that if you did conduct a human factors testing, that it's included as part of that user interface in the testing as part of the overall labeling.
Okay, let's sneak in an online question before we come back to the room. First online question, please.
So we have a question online. They're asking, how is a determination made for which carton and container labeling or PI changes will go for a DMEPA review? And they're also, as a follow-up question, they're asking if you can address that in a pre-market approval space as well as post-market of already approved labeling.
So when those changes are made to the PI or carton and container labeling, DMEPA will be involved for PI changes that might affect Section 2 dosage and administration or other relevant sections. We also are involved in review of the carton labeling and container label. And I'm sorry, Lolita, what was the second part of the question?
The second part of the question is what criteria is used to review that the changes that need to go to DMEPA in both a pre-marketing and post-marketing space? Are there different criteria?
I can try and take a stab at that, Lolita, that question. In terms of the criteria, we work very closely with our counterparts in the Office of New Drugs, and they do have what we basically have given them a list of items that we're looking for in terms of medication safety items that would cause, rise to our attention. And so we work very closely with the project managers so that if they do see changes to the relevant information in the prescribing information, like Ebony said, or the carton container labeling IFU quick start guide, that they would make sure that we are involved in the review of those. In terms of whether that would be pre-market or post-market, DMEPA is involved in every single new NDA submitted, BLA submitted, so we would be involved in all labels and labeling review for all new applications. In terms of post-market, that list would come into play.
Okay, let's go to microphone number 2, please.
Hi there, it's Amy Ebel from GlaxoSmithKline. So I have a comment and a question. So for my comment, I just wanted to applaud FDA on the IFU presentation. You don't know how thrilled I was to learn of your involvement in early IFU review so that you and the company can avoid comments that come late that may affect an IFU that has gone through the validation process. So that was thrilling to hear. And then my question is actually on an unrelated or a separate topic, and that is regarding the patient-focused drug development initiative. And we're already starting to get involvement from our product teams looking at patient experience, patient preference type outcomes that they want to include into their clinical studies that may end up in our clinical studies section of the label. How do you see that type of information impact patient labeling pieces?
I think the patient experience question is a much broader question than just the IFU alone, as you mentioned.
Sorry, separate from the IFU. This is about how the impact of patient preference studies or something that might be in the clinical studies section around patient outcomes might impact patient information, such as a med guide or a patient leaflet.
Yeah, I don't think I can have an answer for that for you, at least at this point. I think it is still being discussed internally how that would be impacting other parts of the label, and so how it would potentially impact patient labeling. I think it's a little premature to comment on.
All right, microphone number 1, please.
Thanks. This is a question for Lori. I guess, same as some initial question we had about how do you determine the patient-friendly term? I guess you don't have the glossary, so what do you do?
So there are several, and again, email me, I'm happy to share them, but there are several kind of glossaries of medical terms whose goal is to be simple. There's actually, United actually has, United Healthcare actually developed, they have 13,000 terms, that's a public resource, for instance, is one. I think it's University of Michigan has an online dictionary, but there's a handful of them around. We really learn through asking patients by putting some, well, the first level is through the expertise of the health literacy experts who've worked with patients for so many years that they know it. And then the second thing is really just listening to patients themselves.
Yeah, at Pfizer, we use MEDRA. MEDRA has the patient-friendly terms as well.
Well, I don't know about that. I have an opinion about that.
Yes.
I can Sure.
Okay, do we have another online question, please?
This is for Lori. Have you evaluated or graded limited health literacy? What is the criteria to define someone as having a limited health literacy?
Sure. So the newest vital sign is well published, so you could search online, or again, I'm happy to share. But there's actually 6 questions, and if you score in the higher end, I think it's a 4, 5, or 6, might be 5 or 6. But if you get at least 4 of the questions right, you're considered to have adequate health literacy. Whereas if you get anywhere from 0 to 3 questions, you're considered to have limited health literacy.
Okay, microphone number 1, please step right up for me.
Right. I think my question is for Ebony Whaley. Thanks for your excellent presentation. I just wanted a clarification. I think you said something about, you have what you call the quick reference guide. It's an abbreviated version of an IFU. I'm just trying to understand. So who develops the quick reference guide? Is that approved by the FDA, or is that, how does that get disseminated out there? I'm just trying to understand it.
Sure. Some sponsors may choose to develop an optional quick reference guide. Again, it's an abbreviated version of the instructions for use, so it might just highlight some key use steps for a given product or device. And again, we reiterate with the human factor studies, it's important that that quick reference guide is also evaluated.
Okay, so by the FDA?
Yes.
Okay.
Okay, and again, if there's any questions in the room, come on up to the microphones, but let's check in to see if there's any questions online. No more rolling in online. Online folks, you're welcome to type into the Q&A pod, but we've got another one here in the room. Please go ahead.
Hi, again, Amy Ebel from GlaxoSmithKline. So this is a little bit off topic too, a little broader, but do you have any impact or information about how the public is receiving patient information that's available on DailyMed, or any feedback on the use of the new format for the patient information leaflet now that it is a little bit more abbreviated? Is there anything coming back from either consumer groups or maybe literacy groups about the impact of that information now available online?
So the answer is I don't know about groups in particular, but what I can tell you, about 3 years in, there was a woman, Spanish was her first language, English was her second language, and she read it and she actually started crying. I was like, uh-oh. And she said, I never understand these, right? And if something went wrong, not only would I know, but I'd know what to do, right? And so that's the kind of patient feedback that kind of keeps us going, right, is when you hear things like that. I can tell you, when we had one of our products approved that was not first in class, there were other labels. We actually, within 2 days of approval, had several advocacy groups actually say to us this should be the model for the labels in the class, that they could see it was a little bit different. So, I mean, we've gotten it anecdotally, so certainly my impression is that people really like it.
Microphone number 2, please step right up close for me.
Sure. I'm Paul Jones in the Office of Medical Policy at the FDA. My question's for Lori. Was there ever, or has there ever been, a product that you've come across in your work that you're performing where you have, no matter what you've done, the comprehension level just didn't seem to move up? And if you could sort of talk about that case study a little bit, I'd appreciate that.
We really haven't. I mean, it's we have had success with every label that we've really tried to tackle through this process in making it clear and simple. That doesn't mean that certain terms aren't harder to describe. That heart failure was a classic example. One of the possible side effects of something was Michael Jackson had the lightening of his skin. That was a really hard thing to find words for, right? So we spent a lot of time. The other thing that we've learned is that over time, you have different therapeutic areas working on different labels. And so politely, I've said, we've tested this now 7 times and it's really well understood. So even though you have a slightly different opinion, is this a problem, right? Because we know this is well understood by patients. And so we spend more of our time, really, I mean, the side effects is the most whatever. The other thing that we hear from patients a lot is, the doctor gave me this medicine for a reason. I know this is a little bit contradictory to where we are today, but gave me this medicine for a reason, and this label is all about the risks, and it's not about the benefits. I don't understand why I should take this medicine. And so I guess just in terms of our evolution, that's another, probably not exactly the question you asked, obviously, but that's the other thing that we hear in terms of the opportunity to improve.
All right. Microphone number 1, step up nice and close for me, please.
Yes, I'd be interested in the panelists' opinion of patient labeling that's created by third-party vendors. I'm not sure of the technical term, but it's stapled onto your pharmacy bag when you pick up your prescription, and that's typically what you find that a lot of patients refer to. As hard as we work on our patient labeling, it might not ever be opened or read or used, but people are looking at that information that's not created by us. So just wanted to get your opinions.
Hi, thanks for that question. Typically, the patient labeling team at the FDA, we don't routinely review the consumer medication information. Is that where you're referencing consumer medication information? So we don't routinely review those pieces of labeling. We try to ensure that the labeling that we review along with DMEPA is consistent with whatever comes out of there, but we don't have any jurisdiction or regulation on what is stapled to those bags. So we don't actually see it at the agency level.
Ed? Okay. Come on, step right up to the microphone for me. Nobody's going to touch that one? Oh, okay.
Hi,
Please go ahead.
Sarah Green from Export Pharmaceuticals. I was just curious for patient information that's been revised with improved messaging for improved health literacy. Is there any research going on to explore whether those improvements are linked to reduced medication errors in the real world?
So no is the honest answer at this point. But I just had someone else start a special assignment looking at metrics because it's a question I get all the time. But there are metrics, I think, if you look at, for instance, I think, we've had 4, hopefully soon 5 labels approved in this format, right? Some others we've not filed or different things, right? I actually think we could do a simple thing like looking at the reading grade level and the comprehension score of like those versus the 5 recent ones. So I think there are some innate metrics, but that is not one of them. What I can tell you is that our safety group is very, very strongly involved in this. In fact, we just did training and hit 75% of safety folks. Actually, somebody in the safety group developed a training on health literacy and did it for internal. So it's something that they're very committed to, and something that is very important. It's to me, if I didn't sit in global health, I should. That's really what this is about.
Okay. Please go ahead. You can tilt that microphone down a little bit and ask your question.
Christine Landy from Otsuka Pharmaceuticals. Great presentations, by the way. This is questions for Lori. It seems like a lot of this is U.S. focused. Is this a pilot that your company is doing for U.S., and are you planning to do globalization to other countries? And if you do, are you going to adapt the same team structure for those countries, or is your team going to handle that?
Yeah. So my team is me. It's
okay.
One person. But what I can tell you is that, oftentimes built and developed right to the global core label. And so there's a bit of a spillover. Sorry. There's a bit of a spillover effect, right? So if you have a clear US label, it forms the foundation of a clear core global label, which then kind of trickles down and is rolled out by regulatory affairs. I can tell you that in Europe, there are conversations happening between OTC brand and generic manufacturers about patient labeling, and I'm part of, I'm looped in through my European European global regulatory folks to those conversations. So it's something that actually I've spoken to the head of our labeling and also the person who has both the labeling and the devices. And they've expressed a desire to make sure that every label that's rolled out globally is health literate. the challenge is manpower, right, as many of us have talked about in many of these situations. So, but the other solution to that is that the writer is typically the same for US and global. And so that's why when I talked about earlier empowering the writers to be more of the advocates, over time, my goal is my role, and it has happened. I speak less and they speak more and they're champions, and that also enables it to be more carried to the global label. But even, there's some requirements of the European labeling. There's a specific order, for instance, whereas in the US, if something is used in men over 70, pregnancy might be more appropriate to be a little later versus something that's women of childbearing age, and you don't have that, flexibility necessarily in Europe.
Thank you.
All right. Any other questions? Step up the microphone.
This is LaShawn. I'd just like to piggyback off of what Lori said. A couple of questions previously. I would just like to thank Lori and Amy and other manufacturers, because the goal of patient labeling is to have a document that will hopefully guide the patient to use the product in a safe and effective way. And it's while also, of course, being technically correct to the prescribing information, because we don't want to tell the patient something that we have not told the prescribers. However, the language should be slightly different, because as we all know, we understand, the large words, we understand the definitions, whereas the end user, the patients do not. And if they get a document that has repetitive information or words that they can't understand, it's not a useful document for them. So there should be that variation. But again, we all walk this fine line of it still has to be technically correct to the prescribing information. And it also, again, we all, I think, Lori, Amy, we all scream for joy when we start talking about patient labeling, so does DMEPA. And especially when we hear there's a lot of people do testing, and they do an open book test, as you discussed earlier, and a closed book test, which is great. But then there's some that's just closed book. And I always say when I'm talking to my team or we're just talking internally, the purpose of the patient information, to me in my head, and I always have a plan in my head, is that when you get that piece of information, and my mother will put it in her junk drawer. That's just where she's going to put it. However, when she needs it, I can say, because she's going to call and ask me what it says. And I'm like, Mommy, please go get it out of the drawer and let's read it. So that's where the useful document comes, so that she can safely and effectively use this medication. So it's not to be used or meant to be used to for the patient to memorize it, for the patient to to know exactly what every line of this document is saying. But they should be able to pull it out of the junk drawer and be able to go to the sections that they need, if they need to, and be able to understand and use that document safely and effectively. And that's what we're working to do every day.
Yeah, please.
So amen to that, and thank you. One of the initial not resistance, that's not the right word, but the first year I was in this role, there was a misunderstanding that people who are well educated would be somehow offended by simple and clear. And we have never found that. And I just didn't want to leave this session without saying that. And so people who want more information will go read the physician labeling, right? They'll go read studies. But at its core, my mom actually is, I think, watching this, by the way. She was so excited. It was broadcast online. Anyway, she was a nurse for 40 years and a head of nursing for people with developmental disabilities. And she was the first one to tell you when my dad was, before he passed away, he had pelvic sarcoma. She was the first one to say, my brain is mush, right? Because it's your dad. If it was anyone else, I'd be fine, but it's your dad. So she would love simple and clear. And so I think it's a universal truth that all of us in some way want simple and clear, and then the ability to go find other information if we want more.